Part 2, Breast Health. Okay, we're going to put into three different categories risk factors. They're separated into high, moderate, and low risk categories. We are going to discuss high risk category first. 99% of all breast cancers occur in women, leaving 1% left for men. The greatest risk for women is between the ages of 50 to 69. They are high risk if they have the inherited genetic mutations of BRCA1 and BRCA2. That could be either or, it doesn't have to be both. Risk is high if two or more first-degree relatives have had breast cancer at an early age. And then the history of breast cancer in a high risk if they have dense breasts containing more glandular and connective tissue. Now the moderate risk. There is a moderate risk if there is a family history in a first-degree relative, and only one, not two. A biopsy-confirmed diagnosis of atypical hyperplasia puts an individual at the moderate risk of developing breast cancer. Another moderate risk is to those who have received frequent low-level ionizing radiation to the thorax, especially during periods of rapid breast formation. And there is a moderate risk during postmenopause related to the high estrogen levels over time, which strengthens the bone density and increases risk for breast cancer. And now, low risk. The low risk category for breast cancer. If you have no children or you give birth to the first child after the age of 30, there is a low risk between menarche and menopause, and then women who have had an oophorectomy before the age of 35 are less likely than women who go through menopause naturally. Oral contraceptives use places the individual in the low risk category for breast cancer. The risk does increase with hormone replacement therapy. The increased body mass, abdominal fat, insulin resistance, and hyperglycemia are also associated with the low risk category. Other risk factors could include alcohol use, high socioeconomic status related to lifestyle differences, and cultural factors. For an example, women of Ashkenazi Jewish heritage have a higher incidence of the BRCA1 and BRCA2 genetic mutations. The American Cancer Society establishes evidence-based guidelines for breast cancer screening in women. Guidelines have not been recommended for screening the general population of men at this time related to the scarcity of breast cancer in men. Men with a strong family history should be screened. The three common screenings are mammography, breast self-examination, and clinical breast exam. By the age of 40, women should be receiving mammograms. Examples of teaching breast self-examination is on page 1595 of your textbook. And clinical breast examination should be performed by a health professional at least every 3 years for women between the ages of 20 to 40 years of age. And then after 40 years of age, the clinical breast exam should be performed yearly. Health promotion for high-risk women should include breast self-examinations and clinical breast examinations, mammography and MRI annually beginning at the age of 30, prophylactic mastectomy or prophylactic oophorectomy. For the plan of care of patients with breast disorders, we will follow the nursing process and would begin with history. For females, obtain the gynecological history such as age-started menarche, age at menopause if applicable, symptoms of menopause if applicable, age of first pregnancy, and number of children versus having no children. After collecting our data related to history, we will proceed with the physical assessment. During the physical assessment, the RN will assess for lesions, palpate axillary and supraclavicular areas, assess for pain and or soreness, identify the location of the mass by using the face of the clock method, describe the shape, size, and consistency of the mass, Assess whether the mass is fixed or movable. Note any skin changes around the mass, such as dimpling, increased vascularity, nipple retraction, and/or ulceration. And then you need to assess adjacent lymph nodes, axillary and supraclavicular nodes. Psychosocial assessment must also be addressed, especially if there has been a lump or a mass identified. This assessment will include asking open-ended questions to obtain data related to fear of cancer, threat to body image, decisional conflict, and uncertainty. Refer the patient and partner to counseling if appropriate. The diagnostic testing that will identify the patient has invasive or non-invasive breast cancer can be a pathology of a biopsy identifying the antigen markers, a mammography, ultrasound, a breast-specific gamma imaging, and/or an MRI. Treatment will be dependent on the type of cancer, location, and the stage of the breast cancer. There is surgical treatment and non-surgical treatment. The surgical treatment includes lumpectomy with lymph node dissection, a simple mastectomy, or a modified radical mastectomy. Non-surgical treatment can be considered the primary treatment, or it can be considered as an adjuvant therapy. Adjuvant therapy is recommended and consists of chemotherapy, radiation, hormone therapy, or targeted therapy. The following diagram provides you with the normal breast anatomy and the surgical procedures that are available. Preoperative care will require client teaching that includes information of the need for a drainage tube, location of the incision, the mobility restrictions that will be identified by the physician. You may also review in your textbook, page 1603, chart 73-2, there are post-mastectomy exercises listed there. You will also discuss with the patient the potential length of stay in the hospital, the potential for adjuvant therapy and general preoperative and postoperative information. And last but the most important, be sure there is a signed consent form for the surgery and the patient fully understands the procedure. The postoperative care will include no blood pressures, injections, IVs, or blood draws on the surgical side. There may be drainage tubes and the care will be based upon facility policies. You want to observe for swelling and infections. There is potential for breast reconstruction after or during the mastectomy. Adjuvant therapy, such as radiation and chemo, is based on the stage of the disease, the patient's age and the menopausal status, patient preference, and pathological exam. Hormone receptor status and presence of a known genetic predisposition. Page 1605, chart 73-3 in your textbook provides more details for postoperative care after breast reconstruction. And page 1606, table 73-5 of your textbook provide information related to the drug therapy for breast cancer. Please review these pages. This concludes the lesson of breast disorders. If you have any questions related to the content of this lesson, contact the instructor.